The EMS gods and National Registry are going to throw you hypovolemic shock patients, and you're going to want to know what to do. Now, when we talk about hypovolemic shock, we understand that the patient is struggling to get oxygen from the lungs to the tissue due to a lack of blood volume. But it helps to start by thinking of what parts of the blood are actually causing the problem: the red blood cells, the platelets, and the plasma. Now, the red blood cells are full of something called hemoglobin, which oxygen binds to, and then the red blood cells act as a vehicle to transport that oxygen throughout the body to the tissue. This is why bleeding control is so important. When somebody's bleeding, whether it's internal or external, we're losing these red blood cells, and the body has no other mechanism to transport oxygen. The other component of blood that we're worried about is platelets. Now, you've read or heard in school that platelets release fibrogen, which causes them to adhere together, create a clot, which can slow or stop bleeding. And that's true, but it undersells just how complex the clotting cascade is. Now, you don't need to know that for registry, and we're not going to go into it in this video. But what you do need to know are some of the things you do on scene dramatically affect it, like temperature. Small decreases in the patient's body temperature can have huge negative impacts on the body's ability to form a clot. If we have a patient with internal bleeding, we can't exactly put a tourniquet around their liver or their spleen, so the best thing we can do is support their natural clotting mechanisms. And if we're keeping the patient warm, we're helping that body form a clot. Now, this means riding to the hospital with the heat on and the patient covered. The other thing we can do to help is patient positioning. Now, as I stand here, it takes a certain amount of pressure to go against gravity and get blood to my vital organs. Let's call it 120/80. But when I lay down flat, it takes a far less pressure, and the lower the pressure in the cardiovascular system, the less the bleeding. Now I want to talk to advanced providers for a second, advanced EMTs and paramedics. The benefit to administering fluids to a hypovolemic shock patient is we can increase the pressure just enough to make sure that the vital organs are being perfused. This is called submissive hypotension. So there's a cost associated with fluid administration. We're decreasing the body temperature, which hampers clotting. We're decreasing the pH, which also hampers clotting. We're thinning the blood, making it harder for the platelets to find each other. And we're increasing the pressure, making any internal bleeding worse. When dealing with an internally bleeding patient, we need to focus not on trying to make the patient better. That's the surgeon's job. We're going to try to keep or push that patient towards the compensated phase. When you administer fluids in the compensated phase, you're actually increasing the bleeding and you're pushing them towards the decompensated phase. When they're in the decompensated stage, you can administer fluids and you're actually pushing them towards compensation. You're paying the same cost, but at least now you're getting a benefit. If the patient's in the compensated phase, they already have the perfusion we're after. The third component of blood that we're losing is plasma. Now, out of all the components, this is our least concern. The reason is that plasma's main function is to transport the formed elements throughout the body. Normal saline and ringers can achieve that goal. Now, it doesn't match plasma perfectly, but it can still move red blood cells and platelets. So far in the video, we went over the category of hypovolemic shock, and there's two types that fall into that category: hemorrhagic, whether it's internal or external, and non-hemorrhagic, which means I'm losing blood volume to something other than bleeding. Now, non-hemorrhagic patients are really only losing plasma. They respond much better to this fluid replacement, but we still don't want to aim for normal vitals. We just want to aim for a perfusing pressure. Now, the new National Registry is focused very heavily on the primary and secondary assessment as well as treatments. But rather than go through some algorithm or list, I want to apply it to an actual scenario. So let's walk through a scenario together. So you have a patient. Let's call him Mr. McGillicuddy. He's at a local pizza shop. He's enjoying his pizza. And some lunatic in the booth next to him named Tom is ranting and raving about how great pineapple is on pizza. Mr. McGillicuddy is not going to stand for this, so he gives his opinion. Eventually, the argument gets heated, and Tom pulls out a gun and shoots Mr. McGillicuddy. Exactly the psychopathic behavior I would expect from somebody that wants pineapple on their pizza. But I digress. So you're responding to the call, dispatch tells you the scene's safe, and as you get out of the ambulance, you got all your equipment, you're working your way towards the patient, and you notice two things: heavy bleeding coming from the right leg and the patient's unconscious. Now, both you and your partner realize the primary assessment's no longer ABC, instead it's CAB. So you pick up the pace and you're gonna stop the bleeding on the leg. Meanwhile, your partner is gonna move his way up to the patient's head to check for a pulse. When he gets there, thank God, Mr. McGillicuddy still has a pulse, but he notices cool, pale, diaphoretic skin. Now, he's not checking a box by noting this. He understands that the color and temperature of skin comes from the blood that's in it, and he realizes between the mechanism of injury, the blood on the floor, and the skin, that this patient's probably in hypovolemic shock. Now, we don't know if it's compensated or decompensated at this phase, but it's safe to say we're dealing with a hypovolemic shock patient. So you're starting to cut away the pant leg, and you want to get eyes on this wound so you can actually get a bandage stuffed into it in an attempt to stop the bleeding. So your partner moves on the airway. Now he notices Mr. McGillicuddy has snoring respirations, and he knows he has two quick maneuvers he can do: a head tilt chin lift if he's not worried about cervical spine, and a jaw thrust maneuver if he is. But with Mr. McGillicuddy unconscious and this being a traumatic injury, we don't know. So he plays it safe. He does the jaw thrust maneuver. As he's doing, his hands are starting to cramp, and he's starting to get worried because he realizes if he can't maintain this, he's going to have to transition into the head tilt chin lift because airway is going to take precedence over C-spine. But just as he's starting to lose grip, first responders walk in. He asks one of them to hand him an OPA. They put in the OPA, and the patient starts to gag. Well, he's there to help the airway, not make it worse by occluding it with vomit. So he goes ahead and removes the OPA, and he didn't note any facial trauma, so he goes with an NPA, does the trick. The snoring respiration stop. Meanwhile, you've got the pant leg cut off. You're trying to control bleeding, but you realize the pressure dressing and the direct pressure just aren't working, so you're going to have to go with the tourniquet. So you're going to go 2 inches above the wound with the tourniquet. So your partner moves on to breathing, pulls off the stethoscope, listens to the lung sounds. Now he notices that the patient has good tidal volume, but an increased respiratory rate. But this is consistent with the field impression you're already forming that the patient's in hypovolemic shock. But he also knows that he has to supersaturate whatever red blood cells are left with extra oxygen. So he asks one of the first responders to put the patient on a non-rebreather. Now, at this point, we don't know what other injuries this patient may have. Do they have exit wounds? Are there additional gunshot wounds? This is why it's so critical that we expose the patients. We can't treat what we don't see. Now, the tourniquet's applied, and you already have the trauma shears in hand, so you start exposing the patient. You don't see an exit wound, but you do see another gunshot wound in the upper right quadrant of the abdomen. So at this point, you realize, well, the external bleeding is controlled, but I have internal bleeding. So you tell first responder, hey, we gotta go. Go get a backboard and a C-collar. So they bring you the backboard and C-collar, you log roll the patient, but you take a few extra seconds to get a good look at the back because you know you're not gonna get another opportunity once you start transporting. So you get the patient loaded, you're on the way to the hospital, you tell your partner, hey, start 2 large bore IVs, hang the bags, but hold off in the fluids until I can get a set of vitals. You get your first set of vitals, the blood pressure is 108/62 with a heart rate of 130. You realize the patient's obviously in shock, but they're compensating. We're maintaining that perfusion, so we're not gonna try to administer fluids at this point. So you call in report and you explain to them you got a gunshot wound victim and you got the external hemorrhage controlled, but the patient still has some internal hemorrhage and that they're in compensated shock. To report, you give a second look over that patient, make sure there's no other injuries that we were missing, and within the next 5 minutes, you get another set of vitals. Next blood pressure is 78/32. You realize that the patient has transitioned from compensated to decompensated shock. Now those fluids are administered. So you and your partner open them up wide at 20 milliliters per kilogram. About halfway through this fluid administration, you get another set of vitals, and you have a blood pressure of 96/54. While it's not ideal, he is perfusing, so you cut back the fluids a little bit. So in that scenario, we were able to tie together primary and secondary assessment as well as treatment. And in today's video, we covered the category of shock, hypovolemic, and looked at the 2 subtypes, hemorrhagic and non-hemorrhagic. We also broke down the components of blood and realized that understanding those can guide treatments and guide us through test questions. We do want to start making more of these videos, but we're looking for topics that you might want covered. Until then, we're going to continue this 5-part shock series, but it would help a ton if you could tell us in the comments what you want. I'm not going to ask you to like, I'm not going to ask you to subscribe. I'm just going to ask you to let us know what it is you want us to cover. Until then, stay safe.